Today we'll be talking about disease states with known difficult airways. This is on the list of topics for the written ABA exam, and the diseases that we will cover are specifically requested to be discussed. I've put a few extras on there for your own utility. Our disclaimer is as typical. Our objectives. Dr. Ramaya, I believe, has discussed approaches to difficult intubation. I've tried very hard not to put too much in there about this as it's covered elsewhere, but I do have a specific point I'd like to make toward the end of the lecture. The entire point here really comes down to a simple fact. We use the external airway exam to mitigate risk and to plan better for airway management. Some conditions are not associated with changes on the external exam, and therefore you need to know about them before you go assess the patient so that you don't accidentally hurt somebody. Among the worst fears in anesthesia is the unexpected difficult airway, and we're going to try to give you a heads up on these risk factors. I'm offering you a clue here just based on diagnosis so that you don't get caught off guard. The fact remains, though, that physical exam is the key. We're not going to be able to go through every disease state that's ever been associated with a difficult airway. However, before you skip the entire lecture, remember, the purpose of this is to keep you from hurting people who you may not appreciate are actually at high risk for difficult intubation or any kind of airway management for that matter. We'll start with the first list from the ABA. In rheumatoid arthritis, this comes up pseudo-weekly probably for most of us. The cervical spine is almost always affected, 80% as I've written here. May manifest as Atlanto-axial instability, cranial settling, which is an invagination of C1 into the foramen Monroe magnum, and some subaxial instability that you'll see very commonly as we do ACDFs routinely. Plain X-ray and CT demonstrate the bony changes, but to assess the cord itself, an MRI is better, and this is what you'll see in the neurosurgical ORs. The degree of cord compression may not correlate with symptoms. Every ACDF that we do, we carefully consider if a typical direct laryngoscopy is the appropriate approach. Here's an image taken from page 633 in the 7th edition of Barish. It's an article from Spine in 1990. And the description is severe spinal stenosis in a patient with completely no symptoms, a completely asymptomatic patient. Although very rare, spinal cord damage after direct laryngoscopy has been reported. The Spine article that I just referred to is actually titled Sudden Death from Cord Compression Associated with Atlanto-axial Instability in Rheumatoid Arthritis. So please be very careful with these patients. Commonly, it'll be our older patients who, my opinion is typically to be very gentle with them as it is. Add to that the diagnosis of rheumatoid arthritis, and you can see a setup for a major complication. More about the disease, since that's what we're here to talk about as well. Intradural cord compression secondary to the rheumatoid nodules can occur. This, of course, would not be evident on an external exam. It also affects other joints related to intubation, the larynx, some vocal cord changes, some hoarseness that you'll hear sometimes, and then often we will see when we use a glide scope or fiber optic video assistance in some way that the mucosa looks a little bit different. We tend to comment on that when we're actually in these cases. The TMJ also can be affected. All this adds up from my perspective and for clinical utility to just be very careful with these patients. There's a whole list of atlanto-axial instabilities that are covered. We won't be able to do every single one, but let's talk about it a little bit more here. This is a lateral cross-table C-spine, typical the neutral position X-ray that you see here. This white line here would be the natural curvature if this C1 tubercle wasn't displaced so far anteriorly. So if you see C1 here, the den's coming up right about here. We now have a measurable space represented by the black line. This does not need to be here, and in fact shouldn't be here. This is the anterior body of C1 over here, spinous process. And if you just eyeball this real quickly, what you should be able to pick up on is what we've outlined here. this natural curvature is gone. This distance has accrued. And for the radiology folks, they will actually measure this window here. And on this particular film, the difference between the posterior surface of the C1 tubercle right here and the anterior aspect of the dens was about 14 millimeters. Just a ballpark it, the typical space there for adults is 3 millimeters. So clearly this represents the Atlanto-axial dislocation that I've commented on here. This is just to give you some idea of what the instability can look like on plain film or CT ahead of time. Another condition that we were asked to cover is osteogenesis imperfecta. I think mostly about these patients in terms of being very gentle in terms of positioning and moving the patient, and we've had a few come through, certainly, one even within the last month or so. But if you read here, this is just an excerpt from the article I put up here out of the nursing journal. You can see I probably underappreciated personally the amount of airway risk, because my default position is to be very gentle with anyone. For example, this case is a perfect prototype of it. Be extra gentle. I would have used a fiber optic scope or a glide scope anyway, just to minimize tension on the bony surfaces that are obviously fragile. This has taught me that I have to be even more careful than I had realized. And here's the basilar invagination I was referring to earlier. This recommends a fiber optic intubation as pretty much your first plan. Use an LMA so you don't have to manipulate the neck. These kind of considerations need to be here, but you can read this as well as I can, and I think this will give you a heads up so that when you hear an osteogenesis imperfecta patient's coming, you don't do what I do and just focus on being gentle, but have a better understanding of your airway implications. Another of the survey of diseases that we'll cover. We'll get into some of them in more detail, but a lot of these I think we just need to highlight a few points. The Keogh Syndrome that I saw as a medical student for sure. I thought this was interesting because of the hyperplasia of the dens. That sounds like a nice, easy setup for a test question for one thing, and a little bit of trivia if nothing else. But you could imagine that these are associated with instability at that axis. There's a whole host of spondyloarthropathies that we will not go into detail. Reactive arthritis, juvenile arthritis, psoriatic arthritis, which we do definitely see a lot of, and occasionally a neuropathic arthritis. I don't see those as often. All need to be considered in your analysis, but the one that the ABA asked us to talk about is ankylosing spondylitis, a chronic inflammatory and actually progressive, migrates up from the SI joints all the way cranially, and progressively so it depends on where the patient is in the process. The classic description for a test purpose certainly is morning stiffness that improves with exercise. They tend to have a loss of lordosis. There is a heavy genetic component to this. The conjunctivitis, uveitis, I put the picture on here just because I thought it would help implant it in your head a little bit more. And it is associated with some otherwise buzzword items like apical pulmonary fibrosis and some aortic valve problems that will help you put the clinical picture together. This is the classic bamboo spine. You can clearly see, I believe, the fusion of the vertebrae here, and this is, all the way up the cervical spine here. This patient's going to be quite a problem for airway management and positioning. And the oldest report I could find of this was actually in a mummy that was over 5,000 years old. So this is not a disease where you can come to me and say, well, I wasn't familiar with it when it's been around this long and been written about this long. Down syndrome is a very common chromosomal abnormality. It's associated with some cardiac defects that you see here. I included the higher incidence of GERD because that will affect your airway management decisions. Something I couldn't remember, increased risk of bradycardia on induction of anesthesia needs to be considered as well. But to get specifically to the airway management component, there is a large tongue on these patients. Interestingly, at birth it's normal. There's papillae hyperplasia that accumulates over time and causes the protruding large tongue. that's characteristic of the phenotype. There's a higher palate, micronathia. When you think about the phenotype of these patients, you often think of the mouth partially open, the tongue protruded. It's those variables that cause that, and obviously to compensate for air movement need there. Large tonsils, some glottic stenosis, so don't try to put the 8-0 tube in. There's really no benefit to going with a larger tube anyway. Short, broad neck. Here's a little bit of trivia as well. Occipital atlanto-axial instability. Typically, we talk about atlanto-axial instability, but in at least one of our question books, it emphasizes that for Down syndrome patients, the trisomy 21 patients, the instability is actually more frequently at the occipital atlantal joint than it is one level down at the atlanto-axial. I've seen this written both ways. I've read 60% at the occipital, and then I've read 30% elsewhere. I think for our purposes, the main point is be very aware of the instability and the danger here, even if it's as simple as turning the head to the side to place an IJ, central access line. They do have hypermobile joints, but of course is also a risk factor for you. Combine that with low muscle tone and the compromised oropharyngeal coordination, and you have aspiration and post-op ventilatory failure risk that all need to be considered when you're discussing preoperatively with the family and the patient, and when you're planning for extubation and your anesthetic plan. A test question will often come up: flexion extension films, are they needed? Are they necessary? Should they be standard to get on a Down syndrome patient before they come to the operating room? We actually don't see these terribly often if you consider the number of Down syndrome patients we take care of. It's very common that the parent or someone over the years has had this taken at some point and will have an idea for you. I can remember a parent saying that our son does have some instability at the neck that they said you would know about. I said, okay, so someone had already looked at this. I'm going to do the same thing either way for airway management, be as careful as I can and not extend the neck any more than absolutely necessary. The caveat about the x-rays is that they're not going to reliably detect instability. You're still going to be exposed to that risk. Some clues, neurologic exam to help you differentiate out who's at high risk from medium risk. Again, I'm not recommending you change your airway management plans based on that though, or neurologic symptoms, some gait instability, hyperreflexia, or clonus is going to give you a clue that that spinal cord has been compromised at some point. You may need a smaller tube, as I said, for the subglottic stenosis. You don't want to be stuck where you get a good a good view of your airway. Don't have it secured yet. Start trying to push a tube in there. It's a little snug. You decide it's smarter to come back out. By now your patient's starting to desaturate and you're rushing and putting more tension on that neck than you could have if you just had anticipated that subglottic stenosis. If they have advanced films, you can measure it, of course, like a CAT scan, for example. And that way you don't have to just guess that a smaller tube is sufficient. To illustrate this point, if you consider the number of patients that actually have symptomatic stridor, if I found a report that says 2% in a Down syndrome population, that sounds like a lot to me. If you consider how many patients on a day-to-day basis have stridor in the PACU, it's not very many. There are lots of mandibular hyperplasias, the Pierre-Robin. These are all in our coexisting disease book and the pediatric anesthesia books discussed rather extensively. We will not go through all of them today. The main emphasis on all of them becomes the same: anticipate problems with the airway, look into the history of the physical exam, and have backup plans in place, including rigid bronchoscopes and teams that are familiar with using them. Acromegaly. This is one that comes up in the neuro operating rooms quite a lot for transsphenoidal cranies. This is a diffuse overgrowth of everything related to growth hormones. So soft tissues up the airway, the tongue, the epiglottis, the cartilaginous structures. They often have a little bit of hoarseness that gives them a clue that something's going on. Certainly gives the physician a clue to what the diagnosis is. Some subtle phenotypic changes combined with the hoarseness is enough to warrant getting a lab draw. Recurrent laryngeal nerve compromise, as I've seen here. Compromised mobility of tissues. The way, in my experience, that I've taught this or practiced this is I'll do a few acromegalics a month, again related to transsphenoidals, and very, very frequently their symptoms, their coarseness of features isn't changed so much that I anticipate a difficult airway. I put a lot of attention into the airway evaluation in the holding room with the resident, and we make a decision. Do we think this airway will be difficult or not? And most often, to be quite honest, the answer is no. It looks like an easy airway. For my personal recommendation is to take an advanced device with you. A glide scope is probably the easiest thing to take with you because it does a few things. One, it gives you a head start if you do have a problem that you didn't see coming based on your external exam. And two, it allows the rest of the team to assess and get a detailed note in case the patient comes back on what the anatomy looks like. I put a star next to mobility of tissues because in my hands and my experience, this is what I've seen being the issue. It's not that the epiglottis or tongue are so large, it's that because of this overgrowth of soft tissues, the mobility of everything is less. So the anecdotes I use are that I take a glide scope from the beginning, just so everyone can see what we're dealing with, and all of the tissues are a little, it's not rigid, but they're a little less mobile than they otherwise would be. And what ends up happening is combine that with maybe a little bit deeper of an airway from the overgrowth, and it ends up summing up to a more difficult airway that I didn't see coming. And this has happened enough times to me that I was thankful I had a fiber optic help or a glide scope help in the room. That's now what I do from plan A. I defend it by saying I'm going to get it so that I can give a detailed exam for the next person who has to anesthetize the patient if they come back soon. In reality, I just know that I'll very frequently not be able to get that epiglottis to move as much as I would like it to get a good view of the airway. Other things that are written about the patients, a face mask, of course, may not sit quite as well. You have to anticipate some glottic stenosis. The ulnar artery insufficiency, classic Allen's test indication here, shows up on tests quite regularly. Please don't forget that. We place a radial arc line in most of the cases that I do, and this needs to be actively considered if it's a relative benefit or not. And as I said, even with a normal external exam, I kept finding that these patients were moderately difficult, and you have up to a 30% incidence of difficult intubations in this patient population. Diabetes mellitus we see on surely a day-to-day basis. This is the classic stiff joint syndrome, limited joint mobility across the board. I've been asked on mock oral boards at least why there are changes in these patients, and here it's written out clearly for you relating to glycosylation and collagen cross-linking. Scleroderma of diabetes is a term I remember from medical school, don't use much, but you often will have this feeling of tightness of the joints, of the neck extension, for example, is what I always think of, between the skin changes and then the joint mobility changes. The prayer sign is the lack of approximation. This is not just a casually pressed together hand. This person is trying to make this approximation meet and can't get it to go away. I couldn't remember the details of the literature on that, so I've added a little bit here. They compared groups of diabetic patients and airway management challenges to non-diabetics, and this looks like a pretty high number, but this is what they have here from the British Journal of Anesthesia. 18% versus 2.5% is a pretty significant difference. Obviously, here's the p-value if you're interested. Here, comparing the prayer sign, it was, approximately twice as often seen in the diabetes group as a non-diabetes group. But if you separate these out to see if using the prayer sign predicts difficult laryngoscopy independent of the diagnosis of diabetes, which of course correlate pretty well together there, they didn't actually see it as predictable. What I find for this is something interesting to get an idea of overall stiff joint syndrome, to reinforce some concepts of interest for the resident. But you're still going to need to be extra careful with this population, again, especially if you consider the amount of times in a day we see this diagnosis. Interesting about stiff joint syndrome is that the degree of control doesn't correlate as well as the duration of the diabetes, as I've written here, for its association with those clinical clues. Obesity is, at least in our world, encountered just as often. I'm really going to emphasize something here. It took me a little while to figure out, so bear with me for a second here. This is specifically directed at the junior residents. I'm asking you to spend a few weeks consciously really thinking about what you see on your airway examination. Try not to go to their mouth opens okay, they have a Mallampati score, and they can move their neck. I want you to think of those not as independent variables, but try to assimilate those into an overall pattern. What made me think of this is the times where maybe my attending didn't do much of an airway exam, I got myself into trouble, and I thought, boy, it wasn't that there was any problem pronounced. If there was a mouth opening that was very small, I would have clearly seen a difficult airway coming. If the patient could not extend at the C-spine, well, that's a very obvious heads up. The ones that would get me are the cases where the additive effect was what does it. So the mouth opening's okay, but it's not large. The tongue's a little big, but nothing I would have commented on. The neck extension's a little limited, but so are a lot of our patients. The jaw protrusion wasn't really there, and I want you to very consciously try to put those things together and see if it changes your predictive skill for a difficult intubation. We have lots of airway equipment available. You might have to wait a few minutes for it, but other than that, I think it's almost available reliably. And see if you can increase your skills for assessment. Often when I see myself or our seniors disagreeing with the junior, like, well, I think this actually will be a difficult intubation, I think this is what we're seeing. We're able to assimilate the findings a little bit better and don't view them as separate, but as risk factors that are confounding, that are additive. I mean, I'm not trying to plug our own system here. This is specifically airway was covered in this article. If you want to read that, it's referenced here for you. But these are all quotes out of the article. Higher potential in the obese patient for difficult mass ventilation, laryngoscopy, and intubation, largely because of the larger tongue. There's redundancy of the oropharyngeal tissue. I always tell people to keep in mind that one oral airway may not be enough on the obese patient. It may take two to get all of that redundancy out of the way. There's limitation of the neck extension. This should be very familiar to you. It's like the head doesn't move back, largely because of the fat pads, the adipose deposition that limits the range of motion of the neck. Your presternal fat pad is what makes it hard to get the laryngoscope blade in the first place into the mouth. And of course, those add up to a difficult laryngoscopy. Higher Mallampati classification from all that soft tissue. And neck circumference, of course, predictive of difficult airway. On a reference, but not needing to go into in this point here. In practice, what you really want to do is integrate all of these clues, this is a carefully chosen term, clues to the potential for a difficult intubation. And I hope and I expect that this will improve your ability to control your risk when you're assessing for intubation difficulty. I tend to put a ramp on the vast majority of my patients. I know it looks silly, but I see it helping dramatically and routinely, especially if you consider that most of our patients are obese. Even the ones that we don't recognize as being very heavy typically are, at least on a population scale. HELP is the head elevated laryngoscopy position. I want you to think of this very much when you're building your ramp. The goal here is to put the external auditory meatus at a horizontal plane with the sternal notch. Okay? This is what happens when I walk in the room and I say, oh, that ramp doesn't look good. You've got the patient positioned on a ramp, pretty happy with it, pre-oxygenating. I come in and say, let's modify this a little bit. This is what I'm assessing. Having some ramp is better than no ramp, I'll give you that, but if we're going to take the time to put the ramp up in the first place, I need to make sure it's maximized, and my understanding, and some of the literature supports, this position is associated with more success. You can see here how it's compensating for the forced lack of extension, forced flexion is what they typically say, because of this fat pad here, or bypassing it if you will, and then it gets some of this tissue here out of the way so I can get a laryngoscope blade in here. I'm going to be soapboxy for just a minute here in the last few minutes. We're approaching 30 minutes for the lecture here. I hear very commonly that the glide scope is a negative. It makes people not know how to do laryngoscopy. The ER physicians, for example, rely on it too much. I feel like I almost have to defend using a glide scope instead of trying to cowboy it and do it the old-fashioned way. But I want you to consider that I used to, as a resident, I felt a failure if I couldn't mass ventilate without an oral airway. Then one day it occurred to me that, wait, I have a tool that I should use if it optimizes my conditions. And I put it in. If my first breath doesn't go in easily, I put an oral airway in as the first plan. If I can't get a radial A-line in within 2 sticks, I call for an ultrasound. I can feel the pulse usually, but maybe I'll see something that surprises me, and a little extra feedback helps me very often, and it offers me the ability to use it when I really need it very comfortably. I think about the neurosurgical literature. We're using a microscope for aneurysm clippings, drastically lowered the complication rate. Now, somebody at some point said, well, if you use a microscope, someday it's not going to be there, it's not going to work, you're losing your ability to operate without one. That's all well and good, but I'm here today with these patients, and for most of the condition I've said here, your plan is largely going to be a fiber optic or a variant on that, which is in this case at our institution is usually a glide scope. What I fear is someone who has rheumatoid arthritis with a reasonable airway that you're a little unsure about, and you don't want to be an anesthesiologist who always uses a sophisticated device, so you pull on that next extra hard, and like the case report, someone gets severely hurt because of your hesitancy to use these advanced devices. Everyone needs to develop a laryngoscopy skill. The junior residents in particular, I want you to really focus on not relying on that glide scope. I hear that. But there are times when using old techniques is not the right answer. We used to put IJs in without ultrasound, and we had a hesitancy to it. If you're putting my IJ in, I want you to use the ultrasound and watch it and stay off my carotid. I think it's the same principle here. Don't let our concerns about reliance on technology let you hurt one of these patients. These conditions are just clues to a potential problem. Knowing that isn't good enough. You have to actually act upon that. I believe that the emphasis from the ABA on these specific disease states is based on the fact that unlike those micrognathia patients, the mandibular hyperplasia patients, where it's very obvious that there's going to be a problem with the airway, these conditions often are not obvious. What I'm doing is giving you a warning that these conditions are out there and are going to try to make you have a difficulty. As such, consider yourself warned, and we'll see you soon.